Good morning, everyone. Myself, I am Dr. Vamsi, working in KIMS Kondapur. After a lot of physics, we'll go through fluid management in ICU. This is more of a fluid. It's not as complicated as physics of tracing, but there are a lot of gray zone here. We have some clarity, but still we need to get a lot of clarity in near futures. So I'll go through a bit of history, how it started, introduction of fluid management in ICUs, Rose model and third hit of shock, what is the significance of cumulative fluid balance, and what are we going to achieve, that is endpoints of resuscitation, and finally what are we giving to the patient, that is types of fluid. Coming to history, administration of IV started in mid 1400s. It's not a fluid, it's a blood transfusion actually, and it is to the Pope 7. Unfortunately, three of the young physician at that time, he involved three of the young donors along with the Pope. They tried to cross transfuse, all four of them have died. After that, there are multiple attempts to, not fluid, but the animal to human transfusions happened, which were never successful. In 1831, Dr. Thomas Lotta, during cholera pandemic or epidemic, because patients were not getting any oral as well as rectal administration of IV fluids, they are failing. So he started giving IV fluids. It was simple saline-like solutions. Compositions involved various components. So he almost 8 out of 24 or 5 out of 24, he made sure his patient success rate, I feel in 1800 that is a good success rate. In 1839, James Blundell is an English obstetrician. He gave a blood transfusion for a woman for a PPH. Later on, the technique has developed and evolved. The fluids became more kind of evolved. In 1913s, the glass bottles were used, glass vacuum bottles, which was a bit costly affair. Post Second World War, it developed much more, and the plastic was invented, PVCs, and it is widely available all over the world. Coming to introduction, the fluid management, where we give, what were the main indications when we give into the ICU or in our ICU? It could be our resuscitation fluid, it could be our replacement, or it could be our maintenance. These are the three major indications where we give our fluids. Resuscitation usually in a shock patient, it could be acute loss of our intravascular volume or it's acute hypovolemias. Replacement fluids is, there is an ongoing replacement of the fluid, which is not, could be either the patient can't take orally or the replacement whatever he is taking orally can't be replaced by his oral. So we supplement additionally through IV. And finally, another indication is the maintenance of fluid, where again there is a decreased intake overall. So we need to supplement his metabolic parameters, electrolytes as well as glucose. So if you briefly try to summarize, these are the three main indications. So during fluid management, what are the four things we need to consider? There is a new concept called 4Ds of fluid management, because before maybe a decade before or 15 years before, if you ask me, the prescription of fluids was very liberal. It's not very precise, or it was not goal directed. Over the last decade studies or development, we have reached a time where we need to consider fluid also as a drug. So drug dosing is important. So we need to consider what drug we are giving, which type of fluid we are giving, what is the indication you are giving. Dosing, yes, like antibiotics, we have prescribed dose like 500, 1 gram, but like most of the drug, dosing is not there for fluids, but still we need to make sure, develop that habit, give proper order and measure its response in the patient so that we can adjust the dosing. So there is no fixed dose, but we need to adjust our dosing coming to fluid. Duration, yeah, as I said, most of us know our starting triggers, that is the patient is in shock, or the patient requires blood, or the patients require only for the dilution of the drug. We know the starting trigger, but when it comes to resuscitation, it's the stopping trigger is the most trickiest part. We don't know when to stop the resuscitation, when to shift our resuscitation to maintenance phase or removal phase. These are the important, where the stopping trigger is important. And for stopping trigger or the change of the fluid, how much fluid we are giving, The entire workshop of today is for that. You can use all the monitor, whatever the workshop your hemodynamic monitoring, so that you can adjust your fluid administration. So whatever the whatever the monitoring techniques you are going to learn are going to update your knowledge, through that you need to modify. And coming to de-escalation, this is till now, as intensive physicians or intensivists, we have developed the practice of going to giving a diuretic or starting a ultrafilter or starting a dialysis to remove the fluid. Before, it was not there. The concept of de-escalation or removal of the fluid from the body has developed, and it has been included as one of the major or one of the important thing in the fluid management. So I'll say my statement will be fluid management in ICUs should be like a fluid state. Everybody accepts here, or you want a rigid state, or it should be fixed? Why? One size doesn't fit all, because usually the response in patients or amount of fluid they require depends upon the vascular and cardiac compliance of the patient. It's not per se, you can't give everybody same. So which part of the Frank-Starling curve the patient at that time, it's not like one day it could be in the bottom of the Frank-Starling curve where the response will be very good, in the next day he won't be in the same state. So you need to assess that patient every day. Based on that only, depending on his vascular and cardiac compliance, you need to administer fluid in him. Especially a patient who have a poor vascular and ventricular compliance, kind of a patient who have poor LVs, or a patient who have ARDS patients, where the ideal fluid balance is not fixed, and it should be achieved with very precisely and particularly with a precise calculation, and where they have very narrow therapeutic windows, during which if we give maybe a few 100 ml or 200 ml of fluid excess also may lead to increased hydrostatic pressure and excessive fluid overloads. So you need to remember the statement of one size doesn't fit all patients. So how to assess the fluid responsiveness? This is an in detail topic. Next, my colleague is going to detail, but we need to know that preload dependence, both ventricles should be in a preload dependent place where when you want to give a fluid, the contractile should be good, then only our cardiac index or the response to the whatever fluid we are giving we can achieve. So when do we say the patients are fluid responsive? If you give 500 ml fluid challenge, there should be cardiac index should be increased by more than 15%. Then only we can say patients are, or the particular person is a fluid responsive. Unfortunately, out of 10 or whatever it may be, if you give 10 fluid challenges in a day or over a period of time, only 50% of the time those patients are responsive. Rest 50% they are not responsive. We are thinking that the patient is responsive patient, it will be helpful. No. So before giving any fluid challenge or giving a fluid, you need to calculate a lot of things. You need to assess, especially not in a resuscitative or a shock phase, but later phase. That I'll come next. So this is, I think, the bottom curve, I think everybody know, that is Frank-Starling curve. This is superimposed with Mark Phillips curve, that is a sepsis curve. If you see A, he is in a responsive phase of curve, where if you give a fluid, there is a large increase in the cardiac output and there is a small increase in the extravascular lung water. But in unresponsive phase, that is B, if you give fluid, the cardiac output or cardiac parameters or index doesn't increase, but there is a large increase in the extravascular lung water. So you need to know at which phase your patient is, and you need to adjust your fluids. Coming to fluid resuscitation, this is a kind of repetition slide. So who are working in ER as well as intensivists who are taking care of ER, we have three different scenarios. One, the patient who coming to ER with acute traumas or body fluid losses, there is a clear-cut indication you can give fluids or blood depending on the patient. Patients coming to ER with a high risk of septic shock, again there is a very clear clarity here, you can give fluids. But patients in the ICU who are already initially resuscitated, they are already under treatment, how we treat such kind of patients? Do we need to go continuous high, like a liberal fluid strategy or a restrictive fluid strategy? This is the tricky part. This is where we need to develop our skill of fluid management in our ICUs. So basic questions surrounding the fluid therapy is when to start IV fluid and which type of fluid, which I come in the later part of my presentation. When to stop fluid administration, when to start fluid removal and stop. So to address some of the things, see, as I said in the initial, there are a lot of gray zone here, or a lot of clarity is missing. So to answer some of these things, they have designed a concept called ROSE by International Fluid Academy, or the similar concept is SOSD, where they have distinct four dynamic phases of fluid therapy, that is resuscitation, optimization, stabilization and evacuation. This is called ROSE, acronym ROSE. So you can see the top part of the slide. First phase is a resuscitation, where the ROSE is bit contracted. By giving the fluid in optimization phase, it is grown big. But to improve the patient, we need to remove the fluid at some point of time. Again, it became very contracted. That is how the ROSE concept is. So in the resuscitation phase, it's a life-saving and the patient rescue. And the fluid is early aggressive fluid management. Here, you need to administer your fluid like as advised by sepsis campaign, that is 30 ml per kg. But here, there is again in this paper or in this concept, they say at a stretch of 30 ml per kg fluid for all patients, they are not encouraging. They are reduced it to a 3 to 4 ml per kg over 10 to 15 minutes and reassess again. So boluses of fluid intermittently and assess the patient's response rather than going for a 30 ml per kg for all patients irrespective of their stage. So this is early aggressive fluid management. This we give for a patient rescue, so that our adequate perfusion happens here and the patient try to come out of his shock. Next is optimization phase. We call it as organ. The concept here or the target is organ rescuing. Patient could be still in hemodynamically unstable, but we need to administer fluid with cautiously, and we need to assess as and when on a regular basis. Here there is a concept called a trawl, that is type of fluid you are administrating, because you need to reconsider your fluid, initial fluid. Maybe you need to add on colloid along with your basic resuscitation fluid. R is type. R is your O is your objective, why you are giving. L is limit. R 1 minute. Sorry, I forgot. I'll come back to you. So type of fluid is either you need to add on your colloid or what. Objective is why you are giving your fluid, whether you want to restore your blood pressures, or you want to improve your microcirculations, or you want to improve urinary pressure, or limit. So where do you want to stop this? So there is always chance of fluid overload as well as underhydration here. So you need to be cautious and regularly assess. Stabilization phase is here. Hopefully the patient, once the patient resuscitated and optimized, he should not be in the shock state. He is off vasopressors, and here we need to supply his electrolytes as well as metabolites, and it should be continuous of organ support. And this phase we target for late conservative fluid management, that is at least 2 days in the first 1 week try to conservative the fluid and try to aim the negative balance here. That is called late conservative fluid management. And it has proven to be it has shown a mortality benefit. And finally evacuation, where we aim for organ recovery. Here either we need to, if the patient enters spontaneously diuresis is very good. If he is not diuresing, we need to add a diuretic. If he went into organ failure like a kidney failure, we may need to initiate the dialysis to remove the fluid state. So this is a continuation of the same concept, that is resuscitation, optimization, stabilization, evacuation. I not go in detail. In stabilization, you need to consider ischemia and reperfusion injuries. And in the evacuation phase, you need to consider a global increased permeability syndrome, that I'll come, ebb phase and a flow phase, I'll come a bit later. And the fluid balance, if you see, in the first phase of the resuscitation, here only is a positive, next all is a neutral, neutral to negative and negative. This is how it should be. It is not like that we have to keep continuous positive, or it should be like, so here you need to understand when our phases are. In a resuscitation phase, usually time frame is in a minutes, optimization is few hours up to 24 hours, stabilization is a week, evacuation is days to weeks. So except in the resuscitation phase, you need to be extremely careful before you are giving, because we are always in a orthodox thing, learning of give fluids that will help. This is another study, just here the concept I want to see. This is, they have compared mortality with a different. This is AEA means early aggressive therapy, LC means late conservative, early aggressive, late liberal, early conservative, late conservative, early conservative, late liberal. This is fluid strategy. Early aggressive therapy, late conservative, early conservative and late liberal. So depending on the clinical stage of the patient, this is a group where there is a highest mortality, that is early conservative and late liberal, and early aggressive, late conservative has to be least mortality phase. So this should be our practice, and we may need to address this. Okay, we need to consider that always keeping a positive balance. Patient is requiring fluid. Sometimes disease process itself demands a lot of fluid. Don't think if need to give fluids, don't think that we are giving fluids. Sometimes it demands, the disease process itself demands a lot of fluid. We need to give, the patient may stay in the positive side. So that doesn't mean that we need to 100% try to do it. Depending on the patient's condition, we move forward, but we try to target this early aggressive, early liberal strategy and late conservative strategy. The same thing, this is anesthesial intensive therapy 2014. Here they said 2 consecutive days of negative fluid balance within the first week of intensive care unit stays is a strong and independent predictor of survival. And coming to, as I said, I will come to cumulative balance. This is critical care medicine 2016, around 2,600 patients. At the end of 72 hours in ICU, if it is a higher cumulative fluid balance, especially the hospital mortality, regardless of AK or CKD present, the mortality is very high. The same thing is supported by the renal study in 2014 by critical care medicine. So I think this slide I shouldn't explain to all of you. By seeing the slide itself, you know that what are the side effects of fluid overload. If the patient enters into a kind of requiring lot of fluid or fluid overload stage, these are all side effects of excessive fluid accumulation in all multi-organ issues. Coming to a concept of ebb phase and a flow phase, any patient who presents with septic shock or an acute insult, we all know there is a surge response and acute vasodilatory phase, and there is a lot of increased permeability, there is a lot of fluid accumulation in the peripheral tissues. In some patients, this goes on, and this is called ebb phase of shock. And with proper treatment or aggressive antibiotic therapy or the removal of source of sepsis or addressing the insult, most of the patients from ebb phase, they enter into the flow phase. That is, automatically the conservation of fluid happens and the removal of the fluid happens. But in some patients, they don't enter into the flow phase. That is, there will be continuous leaking of fluid into the third space, called global increased permeability syndrome. This is called as third hit of shock, and this is the phase where we may stuck with the patients in our ICU, where the patient is developing anasarca, going into multi-organs, why this patient is not improving. So it's a disease state. Sometimes we can address them, sometimes we cannot. So why we are doing? So we have done through phases, we have tried, and one point I want to say is, though this part they have divided into R phase, O, S and E. This is for our understanding, our targeting, but never, there is no clear-cut margins here. There is no, okay, first few hours resuscitation done, next after we need to enter. It's not like that. It is for our understanding, our skill to develop better fluid management, but there is no clear-cut margins here. The margins are always blurred. It has to be a bedside. As a clinician, you need to assess and involve here. So why are we doing? Our resuscitation goals is, if you ask me, improve our organ perfusion so that matching the metabolic demand and supply, so that our oxygen delivery increases and consumption. And how we measure, sir? Macro, micro and clinical. Macro circulation, I think today we know a lot of things. Micro, the major still the lactate, though there are confounding factors here, that is the best surrogate marker still we have. We have mixed venous oxygen saturation, central venous oxidation, arterial venous CO2 gradient and base deficit. These are the micro circulation where we can try to address them so that the micro circulation is better. And the next is the clinically, that is capillary refilling time, mottling time and urine output. So the which I mentioned below, that is gastric tonometry, sublingual capnography, near infrared spectrography, these are all things still under evaluation. In future we may get it. So coming to my last part of presentation, which fluid we should give. So every one of us here knows that there are major two types of fluids are available here, crystalloids and colloids. In the crystalloids again, we have a balanced and unbalanced. What is this balanced concept? We have been so frequently habituated of using normal saline. Why normal saline I kept as an unbalanced solution? And balanced the ringer lactate, plasmolite A or Hartmann solution. So here comes the new concept of balanced versus unbalanced. So a fluid is called as balanced when it's whatever the fluid we infuse into our plasma or into our circulation, it should be neutral, try to be neutral. It should not alter our pH or acid-base balance. That is called a balanced fluid. Why normal saline is? So which decides, or what are the components which decides the balanced fluid or unbalanced one? If you ask me, it's a strong ion difference and the chloride levels of a fluid which decide which is a balanced, which is unbalanced. Strong ion difference is total number of strong cations divided minus total number of anions. Here organic anions are left out, that is usually bicarbonate, and the strong ion difference of any fluid equaling to the bicarbonate our plasma level is called as a balanced level. And the chloride level should be nearly equal to the plasma, that is less or equal to 110 millimoles. So whenever the fluid which contains a SID around 24 to 25, above 24, this is called balanced, and the chloride level should be on the lower side. In a normal saline, the chloride level is around 140 plus and strong ion difference is almost 0. So it comes under unbalanced, and over a period of time, though I come to studies a bit later, there are no significant difference between resuscitation fluid as normal saline with balanced, but there are still, they have lot of reports reporting that because of normal saline there is increased risk of AKI, requirement of renal replacement therapies, patients going into hyperchloremic metabolic acidosis. To avoid all these things, we have shifted our focus to balanced. So what is the evidence? There are few studies, split, smart and salted. Split and smart are double-blinded control study. Split, they have compared normal saline with again a balanced solution. They have not found a significant difference. But here what happened is the amount of fluid used was 2 liters, and in both arms of the fluid the patients have been given 1 to 2 liters of plasmolite before involving to the study. So this is where the results of the study may be compromised. That is what the statement. Next is a smart study. Here there are 15,000, large number of population. The patient, here the amount of fluid used is only 1 liter. Again normal saline versus balanced solutions. Here though the amount of fluid is been only 1 liter given, but the results showing that there is a risk of renal replacement therapy or developing acidosis in the group of patients who use normal saline. Salted is again shown the same result. This is published in NEGM. Coming to, there are summary of other studies ranging from 1983 to 2011. There are some animal experiment as well as randomized observation, multicentric, multiple, and the comparisons are chloride solutions are normal saline versus balanced, and some of the, this study doesn't show any difference, but ringer lactase was associated with hyperkalemia, was less hyperkalemia and acidosis. Here saline versus balanced crystalline, higher mortality, increased transfusion requirement, dialysis in saline group. So there is an obvious reason why we may need to shift to balanced. Coming to colloids, the available colloids are albumin, starches and gelatin. The most here in our practice, our intensive care practice, albumin is the only thing which we can use as a colloid. Though as a resuscitation fluid, albumin may not help us, but once the resuscitation with crystalloid, the balanced solution happens, we can go for albumin. And starches and gelatins, definitely not in ICU. Maybe they have perioperatively to achieve early hemodynamic stability, maybe we have some role with starches. Evidence is Albeo study, it is recently published. Again here, after initial early goal-directed therapy, they have used albumin along with the crystalloid versus crystalloid. The final outcome, there is no mortality benefit with albumin and crystalloid, the combination, but post-hoc analysis and the disease severity with septic shock patient, they have shown to be some benefit with albumin. So these are colloids versus crystalloids. There are a lot of studies, and here I will say most of the studies said there is no, because most of the colloid versus crystalloid studies say there is no difference, and only in the post-hoc analysis or subgroup analysis albumin shown to be some benefit in the mortality group. But the important point here is post-hoc analysis of SAVE trial, albumin is unsafe for TBI. This we need to take home message, one of the take home message. So this, I don't know how far you can see, I just read it out this. A patient presented with sepsis, just a overall summary, because we face with different kind of set of patients and how we can adjust our fluid strategy. A patient sepsis with hypotension, if he is a preload responsive or not, that you know in the next classes whether he is responsive or not. If he is fluid responsive, go for fluid resuscitation mandated here. Consideration what you need to consider in individual group is, if it is a TB, normal saline is, or normal saline is preferred here. Avoid albumin and hypotonic crystalloids, especially lactate. ARDS, go for restrictive fluid strategy. Consider albumin in addition to, early albumin in addition to crystalloids. Abdominal sepsis with compartment syndrome or syndrome of or chronic liver disease, avoid only using crystalloid. You need to consider albumin here. All other sepsis, balanced crystalloid preferred, like burns, trauma, everything. In case of, if the patient is not fluid responsive, you need to consider early vasopressors or inotropes. Confirm your fluid status with echo, ultrasound and everything. So my conclusion for today is, fluid therapy can be double-edged sword. We should understand that one size fits all. This doesn't apply to fluid management. To say one is a fluid response, global assessment is must. Early aggressive and balanced crystalloids. Maintenance, cautious monitoring is required. Colloids and vasopressors. Keep an eye on cumulative balance. Aim negative balance once your stabilization is achieved. So I end here. Thank you.